we're going to ask you to do is to put your questions in the chat later on. We've got people who are going to be watching and helping us with that, but feel free also to raise your hand, and we'll keep a careful eye out for that and try and get as many people involved as possible. So just to kick us off, I'm just going to quickly ask our panel to introduce themselves this evening, and if I could call out names, and then if everybody could say who they are. So if we could start with Jackie. Jackie, you're on mute.
It's a good start. Sorry. Hi, everyone. I'm Jackie Kempen. I'm a midwife and currently a project manager for South East London Local Maternity System. So I work with all of the maternity services within South East London. I'm a midwife of many years, so I've got a lot of experience in having conversations with women and birthing people around vaccines such as flu and pertussis, and more recently as a COVID vaccinator. Yeah, that's me.
Thank you. That's great, Jackie. Linda.
Hi, I'm Linda Machikaire, and I am the head of midwifery at Lewisham Hospital. I'm also the co-chair of the South East London Local Maternity System that Jackie is the project manager of. And I've been a midwife for many years myself, and similar to Jackie, very used to having these conversations. But as a head of midwifery, it's also been very important that as guidance changes, as just in terms of trying to influence that uptake goes up, and that the messaging is correct to women, and that the staff are giving the right message. So thank you for this opportunity to be here tonight.
Well, thank you, Linda, for giving up your time. Okay.
Hello, good evening, everyone. My name is Dr. Oge Losway. I'm a GP based in North Central London. I've been involved with my local vaccination hub as a supervisory GP, and I also started back in April on the NHS England Improvements NHS England and Improvement London region as a clinical advisor. So been holding lots of webinars like this, doing lots of one-to-one conversation. I've been involved in vaccinating my care homes, of which my patch has lots of them, and having lots of conversation with health professionals as well as patients as well through the hub. So really happy to be invited to take part in this discussion this evening. Thank you.
Thank you very much. Gajinder.
Hello, I'm Dr. Gajinder Sandhu. I'm an infectious diseases consultant. So I've had lots of experience during this pandemic on the impact of COVID-19 on adults, not so much with pregnant women, but certainly experience in the past of infections in pregnant women. And I started at King's College Hospital at the beginning of this year. So again, also glad to be here to support the campaign.
Thank you very much for coming this evening. Pooja.
Good evening, everyone. I'm Pooja Dasan, and I'm a consultant neurologist with a specialist interest in obstetric neurology, which is quite niche. I work at Queen Charlotte's Hospital, which is part of Imperial Healthcare NHS Trust in West London. And through the conversations that I've been having through clinic, of course, we discuss their neurology and pregnancy, but more and more now we're also discussing the vaccine, which is where my expertise comes from. But equally, I've been involved in similar webinars like this for other cohorts where vaccine uptake is low, such as in the Black, Asian and minority ethnic groups. And I hope today's evening is just as successful as those.
Thank you very much. I'm not going to introduce them, but also I know that attending this evening we've got other members of the South East London vaccination team who've been supporting us and leading it at different levels. So I think we've got lots of people here this evening who can add to the discussion. So I think what I'm going to do is just move us into that now. If I could just by context say a few words about the vaccination programme here in South East London. So a few facts. We've got about 68 vaccination sites running in South East London, and those are made up of PCN sites, that's primary care networks, where GP practices have come together to deliver vaccines from designated sites. And of course, from those, sometimes there are what we call satellite or pop-up clinics as well. We have about 10 hospital sites which are delivering vaccinations to larger groups, and a lot of those vaccinations are available on the booking system that's run nationally, as well as running sort of walk-in opportunities as well. We also have pharmacies delivering vaccinations, and over 30 pharmacies across Southeast London. So we've got a whole range from very small to very, very large vaccination centres. And as we move through the different cohorts and address the different needs of groups, we can alter and flex those vaccination sites as well. So we've been doing vaccinations in care homes and housebound, and we've got other solutions, for instance, in vaccinating children who are extremely vulnerable. And of course, we've been moving down the cohorts in the order set out by the Joint Committee of Vaccination right from when we started in December. And of course, it wasn't until April that we were written to say we now should push ahead with vaccinating pregnant women. And of course, since then, that vaccination's been available, and we've been encouraging the uptake. Now, as Pooja mentioned earlier, vaccination rates have been fantastic. And what we noticed in Southeast London is that we have high rates of vaccination across the board. We're probably the second highest if you look at age cohort uptake across London. But we notice there's a variability. So, for instance, in outer Southeast London, we notice there's probably higher uptake in some groups than in inner Southeast London. And also, if you break the vaccination uptake by different groups beyond age, so looking at ethnicity, deprivation, etc., and other types of group, you see that there are big differences. And we've had a whole programme working on both hesitancy and concerns around uptake, and looking at trying to diminish any of the sort of delivery of that across Southeast London, and that's been led by a team here. And one of the reasons why we put together this evening's webinar, because we want to particularly promote vaccination for women who are pregnant. So I know there are a lot of questions and issues that colleagues will want to raise, and many queries that are dealt with on a day-to-day basis. So I think what would be a good idea now is to perhaps get into the conversation, and I'm going to invite each of our speakers to say a few words about their own experiences and any kind of messages that they want to pass on, particularly about the vaccination programme. So if I could just invite back in order as we went down. So first of all, Jackie, if you would like to say a few words, please.
Yeah, sure. Yeah, so I guess from my experience regarding the COVID vaccination is that I have been a vaccinator, and initially, obviously, pregnant women weren't being offered the vaccine, and so this raised a lot of questions with women and birthing people around how safe am I when I'm needing to kind of go to hospital and everything else. So there was a lot of fear and a lot of unease around them being able to access maternity services. And then as we have progressed and been able, the data that we're receiving from other countries and within the UK showing the safety of the vaccine for pregnant people, it has just brought to a head a number of questions that women and their partners might have around the vaccination and the safety aspects around that. So I think that it is about being able to have that really good conversation with the women and their families around exactly what the vaccine is, you know, the actual data that's out there and the information that we have access to, that they have access to, and really being able to listen to them and make sure that, because what we think as health professionals they need to know might not be the concerns that they have. So it's really about listening and making sure that we are dealing with their individual concerns. Yeah. Is that all right?
Thank you, Jackie. No, that's excellent. I'm just fiddling with my own technology here. As we move between the panel, you'll notice some slides popping up with some facts. And while I was speaking there, you'll see that, you know, that there's been a lot of observation about the safety of this vaccine for pregnant people. And you know, we're much more reassured than we were previously. And I think it's really important to hold on to those facts as we go through. Linda.
Hi. My experiences are not too dissimilar to Jackie as a vaccinator as well, but I think what's been important for us as a maternity service initially, because I'm based at Lewisham, initially we were giving Pfizer, then we moved on to AstraZeneca. So when the messaging in April came through, we weren't able to offer this. So initially the role was around signposting. And I'm a person who very much believes in grabbing every single opportunity that you have, every encounter with a woman, every encounter with people who are around a woman. So I'll often speak to colleagues, and women will go to trusted relationships or people they have relationships with. And that would clearly be a GP, a health visitor. So it's very important that we do get that messaging right. And where we then went back to giving Pfizer as we went down the JCVI group, certainly what we then did a quick survey of women coming in for their scans, because the majority of women and birthing people will turn up for their scans, 12-week scan, for example, and we did a quick survey over 2 days asking if we were to present you with the scan, with a vaccine when you came for your scan, would you have it? And we had differing results on the two major acute sites within Lewisham and Greenwich, and then it's to what to do with that data. So very much also been involved with our Maternity Voices partnerships and getting that messaging out and using whatever means. So I'll take any opportunity to speak to somebody. And I saw a spectator on Sunday, for example, when I was running the big half, and I said to her, have you had your vaccine? And the woman laughed and she said, yes, pre-pregnancy. But so it's being very aware that some women that were thinking of getting pregnant may not have had the vaccine, and just how important it is to seek sources of information that are the correct sources of information. So they will come to us as healthcare professionals, GPs, health visitors, and so on. So to ensure that we're getting the message across and to signpost them to the right places to go and get it done. Sorry, I do talk on a bit.
No, Linda, did I hear that you were running and giving vaccine advice at the same time? That is multitasking.
Anyone who knows me will know that I do the running and I do the talking about whatever I'm passionate about at the time.
Okay, well that's brilliant. That's exactly what we need. And of course, Pfizer and Moderna are the vaccines that we offer to women who are pregnant. And of course, what's really important is they get both doses, because 2 doses of vaccine give you much better protection than 1 dose. And I'm going to bring in Oge now. Oge, give us your perspective.
Hello, thank you. So I'm a GP. I got involved with our local hub right back when we first started in December. And back then, the questions we asked on Pinnacle, which is the system we use to input the vaccine data, are you pregnant or are you thinking of pregnancy in the next 3 months? So we weren't vaccinating people at that point. And so obviously people are very concerned about why are we chopping and changing and why has information emerged. But it's the first time any of us has lived through a pandemic. The last one was, over 100 years ago. So it has been an anxious time. There's been so much information coming from all sources, fast-paced. And there is extra scrutiny over this vaccine. There was a collective, collaborative, there was political will, all the will to get vaccines. And so we got vaccines quicker than we thought. We got a choice of vaccines. And then they did real life observational kind of studies to look at, and it happened, especially data from the US that emerged. They vaccinated altogether over 100,000 women. They observed what happened. Obviously, women were vaccinated. They didn't know they were pregnant, and then they followed up those pregnancies. And the data came out, it was April, May time, I believe, to say it is safe in pregnancy. Please also go ahead and vaccinate pregnant women. And a lot of people were relieved to have that information and were able to proceed with vaccination. But understandably, women in particular and men were reluctant and said they wanted more information. They wanted to watch and wait and look at all the information available. And since then, we've vaccinated over 62,000 pregnant women in the UK, first dose. And we know that COVID infection itself is really severe, especially in the later stages of pregnancy. So we know protection. We've been vaccinating women against pregnancy for a long time. We give pertussis mainly to protect the baby, and you can have that after 16 weeks of pregnancy. We give every year, we have the big flu campaign, and we invite pregnant women as GPs, and I know that the maternity units also offer the flu vaccine every season. So vaccinating against infectious disease in pregnancy is not new. So it makes sense that we want to protect women in particular, and then by implication their babies. So it is a question of knowing that we're all learning, and it's been a fast emerging, pacey journey, but we're now at a position where we can confidently say that the vaccine is safe in pregnancy and it's highly recommended. Thank you.
Okay, that's really important. You mentioned a really couple of important points there, which is flu and pertussis as vaccinations, absolutely crucial, and been given those for a long time very successfully. So this is essentially following a well-trodden pathway of protecting pregnant women and their babies. And of course, concerns as we've gone on around the impact of catching COVID during pregnancy, etc., and protecting everybody. So on that note, Gajinder, could I bring you in? Obviously, you are at the sharp end in terms of dealing with infections.
Thank you, Andrew. So certainly with this COVID pandemic, as a consultant in infectious diseases, we've kind of seen it unfold. And one of the things I think we were all very afraid of was pictures similar to 2009 when we had H1N1, swine flu pandemic, where we were seeing pregnant women on intensive care units, ventilated. And I remember those experiences because as an adult physician, looking after a sick pregnant woman is probably the most frightening thing we do. And we were rapidly ending up intubating patients, doing emergency cesarean sections, and rushing people over to the Brompton sometimes for ECMO as well. So we lived through this experience of how influenza impacted pregnant women, and we were waiting to see how things unfold with COVID-19. We started this pandemic as adult physicians seeing intensive care units fill very rapidly, but we were quite hopeful to begin with because we were seeing that pregnant women, or early data was suggesting that perhaps pregnant women were not being affected as severely. But COVID-19 has been an evolutionary virus. The pandemic has been evolutionary. And what we've seen is new variants arrive, and we've seen new waves of different populations presenting to the emergency department. The one thing that really made a dramatic difference to us was when the vaccination program was released. So if we think about the first peak of COVID-19, we were getting approximately 20,000 patients in hospital in the country, with approaching 1,000 deaths per day. By the second peak, which was around the December-January time, we were getting up to 55,000 cases of COVID-19, 35,000 hospital admissions, and about 1,200. But what we notice now is a dramatic change in the number of hospital admissions and a dramatic change in the number of deaths. So whereas we're seeing up to 31,000 cases a day, that's 6,000 people in hospital compared to 35,000, and 40 deaths a day compared to 1,200. And the biggest difference is that 62% of our population is double vaccinated. So for us, the light at the end of the tunnel came as you guys started doing this phenomenal work in primary care and in midwifery and in other places to actually get this population vaccinated. As an infectious diseases consultant, I am fearful of infections in pregnancy. We know that malaria can cause death in pregnant women because it sequesters in the placenta. We know that pertussis, we've talked about earlier on, can have significant impact on the newborn, yet we are able to protect that newborn with vaccination. I've talked about swine flu and influenza and how, again, just really pushing the point that that's where our fears come from in COVID-19. As time has changed, though, we have seen differences in data in pregnancy as well. And some of these more concerning data started to come out in August, so this month. The main concern was the number of pregnant women with COVID-19 on the intensive care unit in the country. So again, if I go through those waves, in the first wave, at its highest month in April 2020, we would have had 20 pregnant women on intensive care units. In the second wave, reaching the peaks in January 2021, we're approaching 50. But last month, in July 2021, we had 66 pregnant women ventilated on intensive care units in the United Kingdom. And we also had women who were regarded as recently pregnant, i.e. less than 6 weeks on the intensive care unit. So there were starting to be new concerns. And what we were noticing that of these patients on intensive care unit, 99% had the Delta variant and were unvaccinated. And that's why that fear that we as adult physicians had earlier on, that those images of H1N1, those images of influenza may well be heading towards us again. We talk about herd immunity and we can see the impact of herd immunity in terms of total number of deaths and total number of admissions into hospital. But there are cohorts of that herd that remain unvaccinated. And those cohorts may well be representative of the BAME population, may well be represented amongst pregnant women, and a combination of both. And so the COVID pandemic has been evolutionary. We've seen things changing, we've seen more data coming forward. Also in August, there were 2 publications produced in American journals, the Journal of the American Association of Medicine. The first was a multi-cohort study looking at 18 different countries. And here there were identified increased risks with COVID-19 of preeclampsia, of severe infection, of intensive care unit admissions, maternal mortality, preterm death, and severe neonatal morbidity as well. And then another American study, which again was highlighting pregnant women with COVID-19 in US intensive care units again. And here again, we were noticing higher ICU admissions and the need for respiratory intubation and mechanical ventilation. I think this is incredibly confusing for pregnant women in terms of the advice that is coming forward. As an infectious diseases doctor, I would really want healthcare professionals to highlight that the pandemic is evolutionary, that our herd immunity is evolutionary, and that the virus is constantly changing as well. And what we notice with infectious diseases, there is the interaction between the host and the pathogen. And that interaction does change because some hosts are more vulnerable. And we're particularly going back to that US study it was women of Black African origin and Hispanic origin in deprived areas who had other comorbidities as well that were at greater risk. And I think that is a population that we all recognise within South East London. So, you know, I think it is important that we congratulate everybody for the amazing work that they have done with vaccination, because we've seen a change in admissions and in deaths, but now trying to target those vulnerable populations that really do need this support as this pandemic is evolving. Thank you.
Thank you, Gajinder. I feel so pleased that I've got people like Gajinder and his team there waiting to look after him if I get sick, but I really don't want to go and meet him on his intensive care unit, and I don't want any of my patients to meet him. He's a lovely guy, but I don't want him looking after myself or anyone I know. So I think that's a really strong message there, and I think when we hear those facts, crikey, we've got to find a way to get that message through. Thank you, Gajinder. Pooja, I'm going to bring you in now. I guess that you're used to dealing with some very, very tricky issues in pregnancy, and I'd be really interested, as we all are, to hear your own perspective.
Thanks so much, Andrew. So as I've already said, I am a neurologist, but I work very closely with our obstetricians at Queen Charlotte's, where I run this joint clinic. And usually we're seeing patients with neurological problems. Maybe they pre-exist pregnancy or de novo occurring during pregnancy, but equally we discuss some obstetric issues, and now by default, before they leave the room, we ask every single one of them, what are their thoughts about the COVID vaccine? Have they had the COVID vaccine? And I guess not unsurprisingly, given that there is so much anxiety around this from what we've heard already, and given that the advice keeps changing, this is a cause of a lot of anxiety and concern for our patients, particularly our pregnant patients. And a lot of them say, no, I've thought about it and I'm not sure, they're hesitant. And there's two strands to this hesitancy. I mean, there are some that are diehard anti-vaxxers, and I think we're going to really struggle to convince those, but the majority are just a bit scared. It's a new virus. We're in a global pandemic in the digital era. We hear so much out there and we just don't fully understand it. And then, as we've already heard, the advice keeps changing from the JCVI. Why wouldn't it, as things evolved? We get that, but this is not easy for a patient. So what we do is we let them know what the facts are and take the time to discuss their fears with them. And of course, we've heard the mRNA vaccines, that's the Pfizer vaccine and the Moderna ones are the two that are being used in pregnant women. This is not to say that the others are dangerous in pregnancy, but really the real world data that we've already heard comes from America predominantly, where they were a lot ahead of us in terms of rolling this out. And that's where the safety data comes from. And mRNA, we just reassure them, as we all know already, that the mRNA is injected into the host, and the host then makes the spike protein, which then triggers the immune response. And we just allay their fears that the mRNA is no way interacting with their own DNA, which is, of course, a common misconception. We're often asked, when should I have the vaccine? And the JCVI guidance is clear that they can have this at any time during their pregnancy. There is no prime time, and the first trimester is not a contraindication. We've already heard, and we already know that actually, there are risk factors for COVID, and there is an increased risk in patients of Black, Asian and minority ethnic groups, but equally in pregnancy, this applies as well. So that would be a risk factor. Those patients that might have a high BMI, advanced maternal age, which in pregnancy is above 35, and also whether they have other comorbidities. And if they have these risk factors, we would urge that they get the vaccine straight away. If they're felt to be low risk, then you might suggest that they may get the vaccine later on if they feel comfortable, but not that the evidence suggests that they need to wait. And then we're often asked about patients. I see patients part of pre-pregnancy counselling, for example, epileptics that want to plan pregnancies. And we talk to them about the vaccine. And when they ask about fertility, and of course, there is no evidence from the data that we have, particularly from America, that this impacts on fertility. And actually, if you look at it biologically, there would be no biological reason why it should either. And then we asked about breastfeeding. And again, the JCVI has given us clear guidance with regards to that as well. And there should be no reason that women cannot continue to breastfeed. However, there are side effects, and we warn them of that. With the vaccine, of course, common side effects, as we see with other vaccines, including other vaccines in pregnancy that we've already heard about. But these also occur in pregnancy with the COVID-19 vaccine, the mild myalgia, headaches, fevers, etc. Then we discuss the more severe and rarer side effects. Now, I think the media has a part to play in this. As I said, it's the first pandemic in the digital era, and every time there's a press release about a side effect, no matter how small it is really over exaggerated in the media, causing a whole lot of anxiety. And I think this is an important point, and why there is so much anxiety about taking this up. And this was particularly the case with the AstraZeneca vaccine and the thrombosis risks that were, I guess there was some sensationalism that went on in the media. And of course, we're just trying to allay their fears and tell them this is a very rare side effect. Those that have already had the AstraZeneca vaccine before they get pregnant may choose to still, and we would encourage them to have the AstraZeneca vaccine as their second shot in pregnancy. So in those patients, we would discuss that, but let them know that the risks of thrombosis are very, very small. And actually, there was a lovely infographic that was put out that I saw, which suggested that if the risk of contracting a severe adverse event after a AstraZeneca vaccine is 11 in a million, this compares to 38 in a million of dying of a road traffic accident. And I think you need to give them some perspective as to really how rare these side effects are. And then many will be concerned about, fine, okay, if I get the vaccine, you've told me about that. And as Dr. Sandhu has already laid out, what if I get COVID? And I think we discussed that in detail too. So the risks are to the patient, particularly in the third trimester, of contracting COVID, and the risk to their baby, often of premature birth, and a doubling in the risk of stillbirth. It's a very small absolute number, but it's still a doubling. And that's important to stress, that in the event they contract COVID, particularly in the third trimester, there could be ramifications of this down the line. And in fact, Embrace, which is the maternal confidential inquiry into maternal deaths in the UK. In fact, I'm a reviewer for all neurological deaths that sadly occur in the UK. They looked at maternal deaths from COVID and published this report very recently. So this is UK data. And from the period of June 2020 to March 2021 in the UK, there were 14 deaths in patients who were COVID-19 positive, and they were felt to be 10 deaths directly related to COVID and 4 that were due to other causes. And they looked and they scrutinized all the notes for these patients in a lot of detail, a whole panel of people, and they found that 1 in 10 were not, only 1 in 10 rather, were treated in accordance with national guidance published by the Royal College of Obstetrics and Gynecologists and the Royal College of Midwives. So that's only 1 in 10 in patients where national guidance was followed. So i.e. there were some flaws in the treatment of 9 out of 10. And this I think rings alarm bells. Why is there this reticence or delay in treating these women? We're always worried about the pregnancy when we're treating women, but actually I think we're misplaced with our guidance there. And there is clear guidance. I mean, the recovery trial, for example, even included women who were pregnant and in the postnatal period. So we've got real data, and we've also got real world data. So we shouldn't be reticent in treating these women as we normally would. If they're sick, they're going into ITU, they need to get all the treatment and everything that we have in our armory for them. And actually we found, so there was a reticence from the doctors in treatment, or a delay in initiating treatment because of the pregnancy and not following guidance, but equally there was a delay in patients sometimes presenting. People are still scared to come into hospital. People are still scared to ask for help, and therefore there was delayed presentation as well. And these things, I think, have really raised some red flags for us, and hopefully we can try and address it. And I guess no talk from a neurologist would be complete in regards to COVID-19, with regards to what we're seeing in terms of neurological manifestations of COVID-19. And certainly this virus does seem to be neurotropic, and that's evident from even the minor symptoms that patients developed, with the anosmia, the loss of smell, and the ageusia, the loss of taste. and headache. So there clearly is the virus is clearly neurotropic, and those are the milder manifestations of it. And then very rarely, but certainly we do see more serious side effects, manifestations of this virus, and that can include thrombotic events, and we've seen cerebral venous thrombosis, we've seen strokes, arterial strokes, hemorrhages, and encephalitis, and equally peripheral manifestations of COVID, which can include things like Guillain-Barré syndrome, as we often see as post-infectious in any case with other bacterial and virus infections. So we've seen all of these manifestations of COVID in our neurology wards, and I do discuss that with our patients, that I've got first-hand experience of those, and encourage them as much as possible to take the COVID vaccine as soon as they're offered it. Thank you.
Thank you very much. And once again, great insights in there to the impact of the disease itself, safety of the vaccine, recognizing that, you know, safety is tracked by MHRA, yellow card reporting, it's updated all the time. So we can see that evolving story about reactions. Some reactions are quite common, sore arm, mild fever, etc. But these are common with all vaccinations. Serious reactions, very, very rare. And of course, lots of precautions taken around making sure that people get the right vaccine. Now, I'm going to open up questions now, please. I've got one hand up already. We also, while we're waiting for other questions, we do have some questions on one of the slides, which we think are fairly common questions, which I'm also going to run through. But we've actually got a hand up. Would you like to put your question?
Hi, Andrew. Thank you. Yeah. So my name is sort of lead vaccination pharmacist in Kent, and it's really useful to get the perspectives we've had today, and credit to whoever put it together. I just wanted to really ask the panel around something that's a bit sort of novel, which is co-administration of vaccines to pregnant women. So part of the conversations that we've been having here in Kent, as we move into the next phase, is delivering both the COVID and the flu jab to pregnant women. And I wonder if there is any kind of experience or expertise from the panel around what we should be doing around that. Do we treat them, pregnant women, like we would do anyone else, and do a co-administered dose of both vaccines, or should we be a bit more cautious? This is something that's cropped up in some conversations, so I thought it'd be useful to sort of bring it up here. Thank you.
Okay, that's an excellent and quite testing question to get us started. So could I ask? Yeah.
I can have a go. So I agree, it's a very challenging question. There's two things that I'm slightly wary of. So this last winter, we never really got a flu season. Everybody was wearing masks, people were in lockdown, and we weren't seeing influenza on the wards the way we were before. So we actually don't have the sequencing data that we normally would have to help us predict what a flu vaccine needs to look like. And I'm also wary about when we will get our flu season. And so we may not necessarily go with every typical year where the vaccine's out in September. You may have more information than I do, but I'm just still a little bit concerned that this year is going to be different from an influenza point of view. I think people do worry about side effects of vaccines, and the ones that we know that, as Pooja was saying before, that fever that people get in response to a vaccine often worries people. The number of times I've had healthcare professionals say to me, I don't want the influenza vaccine because it gave me flu. It didn't give you flu, it mounted an immune response. which shows that it was a successful vaccination. And I just slightly worry at this point in time that if we combine the vaccines, we may not be able to discriminate people's anxieties about where the side effects came from. And I also just think if we have hesitancy in just one vaccine, we're probably going to get a bit more people drop out if we try two. But again, I'm not in primary care, and I'd actually almost flip the question back to you. And what would your thoughts be?
Okay, well, thank you. I've got, fortunately, I'm chairing, so I don't answer all the questions, but I've got Ogie here, who is primary care. I've also got Angela Barn in our audience, who is one of our leads on the vaccine programme, a consultant in public health, who's going to help us as well. Ogie, what's the current advice around co-administration?
That we're waiting to see what the JVCI says when they meet, I think end of August effectively. So we are, again, in my patch, we're planning a booster campaign, and the plan is we'd want to give flu in one arm and COVID in the other arm. And from a workforce point of view, from a organizational viewpoint, it makes sense. But there's so many unknowns. So we need to wait for approval, first of all, from the JVCI. And also, we don't know that patients will want both, because in my experience with the COVID vaccine and patients' reports, people were reporting feeling unwell for a few days, bit of a fever, achy, run down. They recovered after a few days. But I am a little bit concerned that given both, then, already people think the flu jab can give them flu. You do educate about the immune response. But if they have both at the same time, will they feel even worse? So I think there'll be some concerns about that. But like anything, even if we start it at the beginning of the program, which is due to start in September, as people get used to it, again, it's an evolving picture. We'll know more by October and November. But from a primary care point of view, we're seeing RSV in kids. We're seeing the normal cold and flu that we normally see in autumn now, as people have been mixing. So I think from what you said, this season we are on tenterhooks in terms of what we're expecting. And we've been told to get ready for an even bigger flu campaign than last year. And it'll be even bigger because of the boosters as well.
Okay. Thank you. That's really helpful. Angela, you would like to come in. Angela, do you want to introduce yourself?
Yes, so thank you very much. My name's Angela Barn. I lead some of the inequalities and vaccination programme. I'm the borough-based director in Bromley, but I'm also a consultant in public health. So what colleagues have said is absolutely right. We have to wait for the JCVI to pronounce on co-administration of the flu and the COVID-19 vaccine, and before that happens, we shouldn't be giving them together. I think that would be the bottom line. What I would say, though, is that traditionally, COVID aside, this country, London particularly, hasn't been particularly good at vaccinating our pregnant women against flu. And really, one of the things that we would all like to see is a much higher uptake of flu vaccine in pregnancy. So we want to do nothing to kind of compromise that at the moment. And in fact, that applies for any group, not just pregnant women. So many practices will be on the verge of starting their flu vaccination programs as soon as the vaccine comes in, and that will be, that'll start coming in mid to late September. If we do not know by then whether we can co-administer it, we should certainly be co-promoting the vaccines when we're talking to pregnant women. We should be talking about all of the vaccines in pregnancy, and we should be encouraging pregnant women to have both. But if we see a pregnant woman and we would like to do the flu vaccine and we haven't got the COVID vaccine, don't delay giving the COVID vaccine. And the reverse occurs. If a woman comes along for her flu vaccine in 3 weeks' time and you've got the vaccine, she's not sure about the COVID vaccine at that time, don't delay giving her the flu vaccine. So it's really important that we encourage and promote both vaccines, but not at the, we shouldn't be waiting for the advice. So thank you for that. I actually did have a question also about fertility. I wondered if any of our panel of experts wanted to say anything about fertility, if there is time at the end.
Thank you, Angela. I'm going to hold on to that fertility question because I think there's some other questions around future effects on unborn children. I'm going to bring, if you want to introduce yourself and your question.
Thank you. This is really a continuation from the previous conversation about co-administration. I'm a hospital pharmacist at Guy's and St Thomas's with a special interest in women with high-risk pregnancies. This is a time of year when obviously we normally give pertussis and flu vaccines, and I think in a lot of the conversation about co-administering flu and COVID, we're at risk of forgetting the flu pertussis combination. And I think, as previous speakers have said, probably once we're talking to women about flu, if we've got it available, we need to remember that pertussis conversation as well, because I have a fear that pertussis numbers may rise significantly over the next few months, as they have done with other childhood infections, and as we've seen with RSV already. So I know when I asked with our infectious diseases team, you know, whether anybody had any advice or whether it was being discussed at the national level, there was a sort of, oh, that's an interesting one. So really, it's just to say to everybody, if you are having these discussions at a local or regional or national level, please don't forget the pertussis campaign for pregnancy as well.
That's really important, and absolutely, we've got to get all of these vaccinations done and make sure that guidance is clear to those who are promoting them. I've got a question in the chat. A couple of questions have come up in the chat which I want to bring up. One is about the sort of impact on sort of the future risks to an unborn child. Is there any evidence that there is a risk? And secondly, another question that we've had put in there, which is how do we deal with family and friends of pregnant patients who do not want the patient to have a vaccine? So sometimes there are other influences at play, and I'd be interested to hear from the panel their advice in those situations. So who could perhaps, could I ask perhaps one of our midwifery colleagues, or Pooja, do you want to come in initially?
Only wanted to just make a point about the first question with regards to concerns regarding risks for the fetus and the newborn. And I think, as I already alluded to earlier, the main risk of COVID-19 infection doesn't appear to be in the first trimester. We don't see increased risk of miscarriages. The numbers that were seen were very compatible with background risk, so no signal there. But those women that contract COVID-19 infection in the third trimester, that's after 28 weeks, are at increased risk of becoming more seriously unwell. And we've already heard about ITU admissions and rarely death. And in those women, they'll often end up having premature births, sometimes iatrogenic, because of course we sometimes, the woman is so sick, you have to get the baby out to be able to treat the mother properly. So often that's a decision made by the obstetric and maternal medicine team. But equally, they can go into premature labour, and there is an increased risk, and it's a doubling in the risk of stillbirth if the mother gets COVID-19 in the third trimester. So that data is there. Now, in terms of long-term data, if you've had COVID, we do know that there is antibody transfer. So actually the antibodies after you've had COVID will get through to the child. And we've seen that in cord blood and also in breast milk. You can detect antibody levels. So in fact, hopefully they will confer some sort of immunity for the neonate rather than anything adverse.
So on that note, and while I've got you there, and others please join in, I'm just looking at the questions on the slide. There's a couple of questions there around when's the best time to have the vaccination in pregnancy, and I suppose that also has relevance to the flu and pertussis question earlier. Is there a best time to get the COVID vaccine, or is it as soon as possible?
That's right. So the JCVI, through all the real world data that we've now got, have suggested that you can get the COVID-19 vaccine at any point during your pregnancy. Those patients that are deemed high risk, and that I've already alluded to, maybe those from the BME background, have advanced maternal age, comorbidities, or raised BMI, those patients are at high risk of becoming more seriously unwell should they contract COVID. So you would encourage those, even if it's the first trimester, to get the vaccine. Now, there may be some that are hesitant, who are low risk, who want to avoid the first trimester. They know it might be a time of, that's particularly that the fetus is vulnerable, a time of organogenesis. And those that want to avoid it, you may respect their decisions for the first trimester and urge them to get it quite quickly as soon as that's over. There's no evidence for that, but you could understand why there might be some more anxiety around the first trimester than there is later on.
Thank you. That's really helpful and very specific information. Could I just ask, perhaps OJ or Jackie, around the sort of support and the conversations you're having with pregnant women or their families and some of the concerns that they raise, and how do you approach that? Jackie, you're on mute.
All the time, sorry. Yeah, I mean, I can deal with two of those questions regarding family and friends, and also about midwives advising against the vaccine. So the first question, and this has come up a lot, I've had experience of speaking with women and also partners. So it goes the same way. Partners want the pregnant woman to have the vaccine, and the woman doesn't want it. So I think in maternity services, we always really try to make sure that it is a family approach. So if a woman raises concerns that she wants to have the vaccine, but her partner or a significant person in her life is really concerned about her having it, we would then want to get together with whoever has these concerns as a group to talk about them. And it's best, you know, having those conversations with and listening to that person and what their concerns are, because sometimes, you know, they're listening to the news or they're reading things on Twitter, you know, and not actually always getting the correct information. So as midwives, we would always make sure that if it was a concern for the woman that somebody in her family was not necessarily supporting what she wants to do, we would engage with them and have that conversation around the vaccine and the effects of the implications of not having the vaccine for that family member. So I would always advise people to kind of open it up and have that wider conversation. Regarding, oh, sorry, go on. Did you want to say something?
No, I was wondering if OJ was coming in. You paused. Carry on.
No, come in. I did pause.
I was just going to report on the healthcare professionals who aren't sure about the vaccine themselves. So we have had reports of, you know, we know midwives, GPs, pharmacists are trusted healthcare professionals that people go to for advice, as well as family and friends. And we as NHS workers, we are a reflection of the general population. So we've had a big campaign as the London board in terms of targeting healthcare professionals that haven't had confidence in the vaccine and providing information. And this webinar is one of the outreaches. What I would say is always approach it from a place of not everyone is sure of all the up-to-date information, because it is such a fast, rapidly evolving piece. And I would always signpost people to every area will have, you know, clinicians, will have people available for clinical conversations and extra information. I will signpost people to the official guidance. So on the gov.uk site, on the Royal College of Obstetricians and Gynecology site, they have really good decision tool aids and up-to-date information for patients and professionals alike. So it's not down to say one person's general opinion, but let's look at what the evidence so far is telling us and make that balanced view.
Okay, I don't know whether you've noticed the chat, but Jitana's just put in and Jitana, I'm not quite clear what health professional you are, but I'm guessing maybe you're working midwifery. but you've said you feel a bit uncomfortable about this without understanding where the data's coming from. And okay, what do you say directly to Chitana then?
So Angela wants to come in as well, but long-term safety data. So we don't have 10 years, we don't have 15 years, but we've got a whole, several generations of using vaccines against infectious diseases. There's been enough scrutiny, enough information thus far. And we do have some information on the long-term effects of COVID itself. So we do need to make sure we balance it with all the information we have right now. Nothing is without any risk, but which is more riskier? And we know COVID infection itself is really risky and has its significant long-term effects, as we've seen with long COVID and other manifestations.
Yeah. My opening sentence when I'm discussing this is quoting how many people have died from COVID, unfortunately, and we heard really passionate testimony from Gajinder early about his experience in at the sharp end of dealing with the pandemic. And I suppose the other way that I put it, and perhaps it feels a bit harsh, but how do you feel about withholding promoting the vaccine to pregnant women when we're so worried about the effects of it? And I think we've got to, have a professional view on that. Angela.
Thank you. I just wanted to come in on some of the comments that have been made about the long-term safety of the vaccine. I mean, it's right. We've only had the vaccine a matter of months, not years. But the vaccine was tested as far as any other vaccine is tested before it's introduced into the general population. So if you think about MMR or any other vaccine, you can only do limited tests on perhaps thousands of, by giving it to thousands of people. It's only when you have given vaccine to millions of people that some of the more rare side effects emerge. Those side effects cannot be predicted sometimes with the when you've done the usual number of tests. So yes, there is a time period that you will probably get more information and more data on. But when you introduce a vaccine into the vaccination program and a new vaccine into the population, you just do not have the long length of time data. And I think the point that's been made about the balance of risk is really very, very well made, and a very strong point if you think about the science and the logic of it. If a pregnant woman catches COVID, her risks are far, far greater from that illness than they are from the vaccine, as we've found it to be so far. So because of the nature of the pandemic, we have given a lot more vaccines more quickly, and we haven't seen a high level of adverse reactions in that population. So I think the longer term risks are unlikely to be more than we are picking up now by the numbers of people that we're vaccinating, if that makes sense. So I've heard this many times from people that have said to me, we haven't tested this vaccine properly. The vaccine has been tested as any other vaccine would be, and before it would be introduced into the general population.
Angela, that's really helpful, and there's kind of a bit of myth busting there. And obviously, it calls on all of our professional skill set, and we're often, and particularly within midwifery, obstetrics, you're used to discussing risk with people because there are so many unknowns, and I think here we've got to make it clear and simple, the information and that's presented to patients. Angela, as you're there, do you want to quickly ask your question around fertility? You're on mute.
I just wondered if any of our resident experts would like to comment on some of the comments that have been made about fertility and the risks with fertility. This is another myth, really, as far as I can see, but I don't know if.
So we've said clearly.
I could have a go at this because it is a myth that comes up quite frequently. So I'd worked in South America and Africa, in India, and quite often where you've got vaccination campaigns, this myth arises that the polio vaccine is going to impact fertility, and quite often The conspiracy theory goes even further, saying that this is a Western conspiracy that's going to, stop fertility in our populations. And from there, this sort of fertility impact just seems to sort of expand because it is something that people fear. But as Pooja said before, there's absolutely no biological reason why fertility should be affected by something that is boosting your immune system. This is not chemotherapy. This is not radiotherapy. This is not radiation. This is not something that's targeting your ovaries or your testes. It's not affecting reproductive cells. So biologically and historically, no vaccine has caused any impact on fertility.
That's very clear, and I think in the studies that were done at the beginning, the rates of fertility in those who were vaccinated against COVID and those who had placebo were the same afterwards in the initial studies. And again, we continue to observe no impact on fertility. There were a number of other questions on the slides. We are coming to the end of our session now. I want to thank everybody who's contributed today. Thank you so much to the panel for making their time and dealing with a number of the issues. This has been recorded, and that hopefully this recording will be made available to more people to watch. With that, I'd like to say thank you very much to everybody for everything that they've contributed, and I'm going to close this evening's meeting. Thank you very much for your attendance this evening.
Thank you.
Thank you.